Good afternoon to one and all present. A warm welcome from FCPI Infectious Diseases Forum. So today we have joined here for yet another interesting discussion on a very crucial topic, which is diagnostic stewardship, a perspective from clinical microbiology. So we have gone through a lot of sessions before through ID Forum itself, and I think today's topic is the most crucial one because as we know, we cannot treat a person or a patient unless we know what we are treating. So we need to know the organism, what kind of antibiotic or antifungal it's sensitive to. So I think the clinical microbiologists have a very important role to play there. So I think there is no one better to talk about the same topic, and we are very pleased to welcome Dr. Sharmila Sengupta, ma'am. Thank you so much, ma'am, for accepting our warm invitation and taking your time off to guide us through this wonderful topic. Thank you so much, ma'am. So before moving on to the slide, just a quick intro about our speaker. So Dr. Sharmila Sengupta, ma'am, she's the Associate Professor and Senior Consultant, Department of Microbiology, Amrita Institute of Medical Sciences and Research Center, Faridabad. She has done her MD, Medical Microbiology from Kasturba Medical College, Mahe, Manipal, Karnataka. She has done her MBBS from Burdwan Medical College, Murdan University, West Bengal. Previously, she has worked at National University Hospital, Singapore, Department of General Medicine as a research staff for COVID-19 research studies and National Center for Infectious Diseases, Singapore, Department of Infectious Diseases. She has previously worked as senior consultant and head of infection control and clinical microbiology in tertiary care hospitals in Delhi NCR, India Medanta, the Medicity Hospital, Gurugram, BLK Hospital, Delhi, Fortis Hospital, Noida, and Kailash Hospital, Noida. One of her main achievement is she's the first Shia ambassador from India, and she has contributed in WHO-led guideline committees. And she's very passionate about training and capacity building in IPC. She has over 60 publications in national and international journals. Once again, ma'am, thank you so much for accepting the invitation. We are looking forward to looking into your slides. So over to you, ma'am.
Thank you very much. A very good afternoon to all the participants, and thank you, for inviting me. It's really an honor and a privilege to be able to talk to you today. The topic which was assigned to me is talking about diagnostic stewardship, the perspective from clinical microbiology. Now, before I start with the actual topic, I would like to go through a little bit of history where, we started with in, say, 2000 BC, when what was happening if you had an infection or a fever. So we would say, here, eat this root. When we came to 1000 AD, that became the root is heathen. Here, say this prayer. In 1850, the prayer became a superstition. So drink this portion. Then 1920, that portion is snake oil. Swallow this pill. 1945, this pill is ineffective. Take penicillin. 1955, oops, the bugs mutated. Now take tetracycline. 1960, 1939 more. Oops. Here, take this powerful antibiotic. 2000 AD, the bugs have won. Here, back to the roots. Eat this root. This was put up by somebody anonymous and cited in the World Health Organization. So I find it very interesting, how we are closing the circle and going back because of antimicrobial resistance. So what are the untoward effects of antibiotics? One is, of course, the most important, the antibiotic resistance, which is supposed to be the silent epidemic, which is happening all over, pandemic rather, happening all over the world, which increases morbidity and mortality and length of stay in the hospital. Adverse drug reaction. This, of course, as pharmacology, pharmacy people, you know much better than I do, hypersensitivity and allergy, other side effects, C. difficile infection, antibiotic-associated diarrhea or colitis, and of course, to top it all is the increased healthcare cost. Now, what led to diagnostic stewardship? The concept of antibiotic stewardship started in 2007 when this paper by T. Dellett came out in CID, Clinical Infectious Diseases, talking about antibiotic stewardship, where we started recognizing the problem of AMR and what we could do to control AMR, though we haven't done much really, even after everything. But the concept of diagnostic stewardship is much more recent. And what had led to diagnostic stewardship is the symbiotic relationship of antibiotic stewardship, or ASP, to diagnostic stewardship, or DSP, which became more evident and has become essential now in today's practice. We have to recognize the presence of infection. We have to find out the definitive pathogen and antimicrobial therapy options, which obviously only after finding the pathogen we can find out the therapy options. So early and accurate diagnosis of an infection improves treatment efficacy, can avoid long-term complications, and of course prevent transmission, lessen the misuse of antimicrobial therapy in the process, reduce the cost. So by definition, diagnostic stewardship is a systematic approach to the effective use of the microbiology laboratory and the microbiologists in clinical practice in order to deliver safer, more effective, and efficient patient care. The primary aim is to benefit the patient and ensure they receive the correct treatment. So proper use of diagnostics also help to understand the prevalence of pathogen in general, what is the burden of AMR in that particular geographical area, and how to contain it. And so the place of diagnostic stewardship in antimicrobial stewardship is patient management. That's the core of any stewardship. So it is defined as a series of coordinated system or user-based interventions that are designed to promote evidence-based utilization of diagnostics tests. Now, if you look into the jargon of English, it might sound a little difficult, but as I go on, I will explain to you and very simply what is diagnostic stewardship. In the context of antimicrobial resistance, we have to practice diagnostic stewardship in a systemic way and to address the role of microbiology laboratory, especially in cases of infection. Now, if you look into this diagnostic stewardship or antimicrobial stewardship, they ultimately fit into the infection prevention and control program. And that is where we all as a multidisciplinary team, whether we are microbiologists, whether we are pharmacists, pharmacologists, or ID physicians, or critical care people, we all work together. And of course, the nursing staff, we work together to contribute in controlling AMR or antimicrobial resistance and for the safety of our patients. What are the questions we are asking? What do clinicians seek from the microbiology lab? There are three basic questions. Whether the patient is infected, if yes, with what? And what will we treat it with? So these are the three basic questions which we need to answer from the microbiology lab to enable patient care. Now, the puzzle is to fit in the diagnostic microbiology into stewardship practices. So what do we have in the microbiology department? We need to, in order to support the stewardship program, we need good infrastructure and good functioning. Preferably, it should be a 24/7 lab, which is in most of the hospitals, we do have 24/7 labs. We need trained manpower. We need the availability of a clinical microbiologist definitely with experience and knowledge. Receptiveness of responsible physicians. That means when the microbiologist is talking to the clinicians, it should be a bilateral communication where we can discuss cases, where we can look into each other's issues regarding the patient and then resolve it together. Of course, IT support in today's day, the importance of IT support is we can never undermine it. And also liaising with other clinical departments and having some quality assurance and safety checks. So what do we do in the microbiology department? We should be able to systematically select patients who will benefit from the information and try and assign proactively a fast track protocol, because in in my time when I was a student, microbiology was a very slow process, and clinicians used to lose their patients waiting for microbiology reports. So we do have to have some fast track method, and we should develop diagnostic routines for same day prescriptions, same day reporting, and preferably getting some information regarding the patient also, and what we are looking at in the lab. Then expert opinion is usually made up of a medical microbiologist with all the information in the lab, and we should be able to communicate with the clinicians at the earliest possible time. And whenever we are reporting any microbiology report with pathogen identified or not identified, we should be able to talk to the clinical pharmacy, we should be able to talk to the pharmacologist as well as the treating physician, that what would be the best of care when it comes to using antimicrobials. So the workflow, let me explain to you a little bit about the workflow in the microbiology lab. It doesn't start in the lab, it starts in the wards, it starts in the OPD or in the clinics, where there is a pre-analytical portion where the test has to be ordered, a proper collection has to be done, sample collection. As you know that microbiology samples are not something, not like biochemistry or hematology samples where it's just the blood or the sera, but it could be anything starting from the hair to the toenail. So collection of sample is very, very crucial in microbiology, proper reporting. Then transporting that sample. In my time when I was working in a government setup, I remember that our professors would order a test. We as residents would they would order the test at 9 o'clock in the morning. We as residents would collect it at 10 o'clock or so maybe 10:30 in the morning. And that sample, the person who would collect the sample, go around the whole hospital collecting samples, having tea, chatting with friends. And by the time they landed up in the lab, it was 4 o'clock in the afternoon. So early transportation is very crucial in getting a correct, proper reporting also. The analytical part happens in the lab where the samples are processed and the tests are performed. Now, post and analytical is also a very important area where the reporting, the documentation, and the action which has been taken based on the report is also known. The multidisciplinary team, which is the microbiologist, the clinical pharmacist, pharmacologist, and the ID physician, the treating physician, the primary physician, we all together talk and there is an action based on the report. So in pre-analytical, careful clinical evaluation, recognition of an infectious syndrome, and estimates of the pre-test likelihood of the condition is very important. If the pre-test likelihood is less, we are likely to get false negative reports. And false positive reports can also become one of the outcomes if the likelihood of the test is not recognized by the clinician. If the clinician is suspecting that there's a sepsis and orders for a blood culture, we are likely to get the best report. But if the clinician suggests sepsis, thinking of sepsis, and sends just a urine sample or maybe a sputum, then we are likelihood to get either false positive or false negative reports. So it is the most vulnerable part of the total testing process, and it is amongst one of the most challenging places, significant challenges to the lab professionals. Pre-analytical, obviously the physician's decision to order the test, collection by the nurse or the phlebotomist, the correct sampling, the correct way of sampling, and transportation is either manual or mechanical through chutes. But this is also very important, and it should be as in shortest time as possible. So microbiology stewardship starts with obtaining cultures prior to starting of antibiotics. It has been seen, many of the the studies have shown, this is just an example, that if you give the antibiotic prior to collecting cultures, you are less likely to get an organism growing. So develop the process to ensure that cultures are properly and consistently ordered, obtained, transported, and processed. And also, whenever we are looking for an infection, the sample should be collected before starting empiric antibiotics. So this was another study where the guideline-based intervention to reduce culture ordering, it was seen that, when you intervene and this was a pre-post study with a control arm in two VA systems in US, where they found that the diagnostic algorithm, based upon some guidelines, how well they work, and when you give an audit and feedback or case-based presentations, it actually helps you to reduce all the unnecessary cultures. At the same time, it helps you to get the correct sampling and when culture is required. So this was done on urine, and it was found that the over-treatment of asymptomatic bacteriuria also came down because of this intervention. In the lab, we always say, that garbage in is garbage out. That if you don't collect the samples properly, if you don't transport it properly, if you don't have the adequate volume and the proper sampling site, you are likely to get garbage out of that sample. Now comes the analytic part. Let's talk a little bit about what happens in the lab. So we have to do a specimen screening. It's very important that we know what kind of specimen is required for which test, and whether the specimen which has been sent is of any value to process. So there is always, along with specimen reception, there is always a rejection criteria. Good labs always have good rejection criteria, so that we know that this specimen which was collected is the right specimen. A sputum sample could only have saliva. So that is not something which is acceptable, because a sputum is supposed to be coming from a place which does not have a normal flora. But saliva would come from the mouth, which has a normal flora. So you are likely to give a wrong sample if it is labeled as sputum and you are processing saliva. So these are certain things which we need to look into. Implementing testing algorithms. The microbiology lab usually have testing algorithms, that if we have a urine sample, if we have a sputum sample, if we have a blood sample, how are we going to proceed? And we would always look forward to doing a rapid identification and sensitivity when necessary, especially in the hospital setup. The laboratories in the hospital, it is very essential that we are able to deliver the reports, the identification and sensitivity, as early as possible. So what is done in the laboratory? So we do cultures, and then we put up sensitivity. Cultures are usually done on agar plates or in liquid broth, and then sensitivity, whenever we have some growth of the bacteria, we pick out a pure colony and then we put up for sensitivity. therapy, which can be done on a microtiter plate. It can be done by disc diffusion, or it can be done by E-strips. There are different ways of doing antimicrobial susceptibility, which could be qualitative, that is reporting through a disc. The clearing around the disc would tell us that this particular pathogen is susceptible to this particular antibiotic. But it is a qualitative report, which we only say that either it is resistant or susceptible, or if the zone size is in between resistant and susceptible, we say it is intermediate susceptible. Quantitative reporting of antimicrobials is what we need to do. In today's day, it has to be a quantitative approach. It is known as minimum inhibitory concentration, or MIC. That is the smallest quantity of antibiotic that inhibits growth. This can be done in liquid media, which is broth dilution technique, or in solid media, or by e-test. Ensure in the lab, what do we need to do? Ensure that you have standard protocols in place, so that it is a standard protocol, and training of the technologists and technicians in the lab is very important, so that no matter who is posted, things will be sampled and processed in the same manner. Educate all lab staff on the protocols at regular intervals. Please remember that laboratory technicians are a very transitioning population, where they, some of them are always looking out for better opportunities, and they keep moving. So we have to have some processes in place where we are taking care of their education and orientation to the lab work on a frequent frequent basis, and to teach them. Only the experienced staffs are able to differentiate between contamination, colonization, and infection. This is very important when we process our samples in the microbiology lab. We should be able to make out, this comes out of experience and training and teaching, that, oh, well, this sample is contaminated, and whatever is growing is basically a contamination either from environment or from the person who has sampled, who has done the sampling, or it could be a colonization, the flora from the skin, the flora from the mouth, or from the genitals. So we have to be very careful about differentiating between contamination, colonization, and actual infection. Then we also need to encourage clinicians to provide us with some basic clinical information, so that when they order the diagnostic test, we can also look into the clinical validity of what we are doing. Then, of course, implementing monitoring, audit, and feedback for all processes carried out in the lab. Cascade reporting, I'll come to cascade reporting. It often helps the clinicians and also helps the pharmacology and pharmacy in monitoring or regulating their antibiotic prescriptions. Turnaround time is also an important aspect of microbiology reporting. As I told you, in my time as a student, the microbiology laboratory, nobody used to wait for the reports. The clinicians would just start off with the antibiotics, saying that by the time the microbiology report comes in, we've either lost the patients or the patients have deteriorated. So it is very important that the turnaround time should be minimum as possible. Now comes the post-analytic interventions. Here is where the clinical pharmacy, clinical pharmacologist really play a very important part. So we need to modify our reports from microbiology lab and improve the practice and collaborate and combine the reporting with the ASP team. One of the methods is cascade reporting or selective reporting of antibiotics, giving clear instructions and opinions to guide therapy. We can, at the microbiology lab, the clinical microbiologist can actually give certain suggestions regarding use of antibiotics or relating to the patient's condition, and also provide with some opinions to guide therapy. regarding the pathogen which has been identified. We often, clinicians are busy with their clinical duties. So often we kind of forget that they may not have that much of knowledge regarding pathogens, and we should be the ones who are there to guide them. Cumulative reports or generating antibiograms are also a very helpful way of helping them to decide on empiric therapy. So this, the left-sided picture is talking about cascade reporting. Cascade reporting. WHO has come up with what you call a classification, which is known as the AWARE classification. That is access, watch, and reserve group of antibiotics, which we can utilize in the microbiology laboratory while reporting, where the access group of drugs should be reported. We should only report the access group if there are enough number of susceptible antibiotics. These are the basic antibiotics which are available, and only go to the watch group or the second line of antibiotics when more than 3 class of antibiotics in the access group is resistant. And if even in the second line or the watch group there are more than 3 classes which are resistant, then only the reserve group of antibiotics is released. Now, this is often a very difficult task in our setup, the Indian setup, because the clinician wants everything. They want to choose their antibiotics, but this is one of the ways we can really control the use of antibiotics. If we are only reporting the access group, which shows a very good susceptibility, we can talk to the clinicians and say that please choose from this group because these are more narrow spectrum drugs. They are easily available. They are usually the less costlier drugs, and the pathogen which is present will definitely respond to these drugs. So misuse or inappropriate use of high-end antibiotics are prevented that way. And then there's something called an antimicrobial stewardship huddle, or that the microbiologists, the clinical pharmacist, pharmacologist, the ID physician, they all get together and discuss certain reports or certain outcomes from the microbiology laboratory to the best of utilization of antimicrobials for patients. Now, long term is developing antimicrobial resistance, but short term is all that pumping with expensive antibiotics when the patient is responding or not, and increasing IV drugs, or increasing the length of stay of the patient when it is not necessary. These are all the things which can be resolved through multidisciplinary huddles. Now, what is an antibiogram? An antibiogram are important resources for any healthcare provider who are dealing with infections. What is it? It is analysis and presentation of cumulative antimicrobial susceptibility data. Now, this can be done in different ways. The pictures are some examples of antibiograms. Let me show you the one which we use in our hospital. What we do is a cumulative data which is analyzed according to the important gram-positive pathogens which we have in our hospital and the important gram-negative pathogens which we have in our hospital, and match them with their sensitivity pattern, susceptibility pattern. So when you see these red dots, that means these antibiotics will not work. Like for an example, if you're looking at Staph aureus, we know that ciprofloxacin, levofloxacin, erythromycin, these are some of the antibiotics which will not work if there's an infection with Staph aureus. So this is a very important step in guiding the clinical pharmacist, or guiding the ID physician, or guiding the primary physician in what would work if you're suspecting a certain pathogen for a patient. And in our it actually is an hospital epidemiological data, which tells you that if you have this particular pathogen, say Klebsiella or enterococcus or a salmonella. In this region, these are the antibiotics which are likely to work, and these are the antibiotics which will not work. So post-analytic releasing of reports, as I told you, is cascading of the results, that is according to the WHO AWARE classification. We need to look into the local resistance issues, which would again help in forming the treatment guidelines and should help in clinical decision making, and then work as a collaborative team, laboratory, pharmacy, ASP team, IPC team, and the clinician leaders. These are some of the studies which have been done across the world, showing that appropriate therapy, 80% in the treatment arm versus 53% in the control arm. When you use a multidisciplinary team, when you use this diagnostic stewardship, antimicrobial stewardship, how well it works for the patient and the clinician. So now, our country being a lower middle income country, what are the challenges? The first challenge is the logistics. How the sample is being processed, how it is being transported, where it is being sent. There are many small hospitals which do not even have a microbiology lab. So what happens when they do not have? They have to send it to some other reference lab. So the logistics is very important. Poor fit with the user's needs. So if culture is the most important test which you need to do, and we don't have that facility, say for TB culture, most of the small microbiology labs wouldn't do a TB culture. So if a patient is suspected, that could be a patient suffering from pulmonary TB, and if your lab is not providing TB culture, so that is a poor fit. You are getting a lot of TB patients and you still do not have any means to diagnose it. Cost is always important in our country, a poor, lower middle income country. I think cost is always something which is always calculated when you do any test, when you set up a lab, when you do any test, you order any test, and you look into the patient profile. Workforce, getting trained workforce is a very big challenge. And having a proper infrastructure and access to that infrastructure is also a big challenge. Then weak regulations. You know that antibiotics, though it has been categorized into the age group of drugs, they all come with that red label, but still the regulation is not strong enough. And for all this, we feel that the political commitment towards antimicrobial resistance is still not really there. Solutions, health system strengthening with patient-centered delivery, strengthening of innovation process, improved knowledge base, behavior modification. This is very important when it comes to behavior of the clinicians, especially. And clinicians, in our system, there's a hierarchy where the clinicians always think that they are a cut above the clinical pharmacist or pharmacologist or microbiologist or the biochemist. That mindset has to go. Even a nursing staff can point out that, what the clinician is looking into may not be the most appropriate thing to do. And this has to be accepted. We have to learn to accept all people participating in a team for patient care, and we are all at equal level. And we are all sitting on a round table and there is no head and no tail. So harmonized guidelines have to be created and evaluated from time to time. The supply chain has to be maintained. This is very important, that a supply chain needs to be maintained, and mechanism for ensuring quality and capacity is also a very important aspect of the lab in the whole process. So in summary, I would say the microbiology lab has to be, the diagnostic stewardship and the microbiology lab has to be integrated with ASP. Optimal test ordering, sample collection, transport, screening of the sample, rejection criteria, doing reflex testing. That means if a sample has been sent just for routine urine microscopy and it is found in the lab that there is plenty of pus cells in the urine, there's bacteria in the urine, we should be able to tell the clinicians, okay, we are proceeding with the culture because this looks like an infection. So reflex testing, using rapid methods, using biomarkers for infection, susceptibility reporting, have cascade reporting, cumulative antibiograms, and this has to be translated from bench to bedside. That is bringing the lab closer to the point of care. Of course, we need to endorse newer technologies for rapid diagnosis. There are pros and cons. Obviously, cost is a very important factor, and also administrative will is a very important factor. So communication and collaboration as a multidisciplinary team is very important to go around. In summary, I would say the lab has to be integrated. The same thing, and novel and future diagnostic approaches may challenge ASPs with too much information, but we need to learn how to sieve them out. The old concept was antibiotics are miracles. The concept has changed. So the new thought would be, it is good when used well, better when it's used thoughtfully, and best when it is used with in a planned manner and taking a multidisciplinary team into consideration. Well, the struggles, it is said that it is a luta continua, that is, the struggle still continues. Thank you.
Thank you so much, ma'am. I think the presentation was really wonderful because you covered all the basic concepts very well. Because as we all know, I mean, we just look into the cultures and we are just focusing on, okay, what's the organism and everything. But there are a lot of hurdles that as clinical microbiologists, you all have to go through and you all have to face. And you just explained it in a very simple manner. So thank you so much for that. And I think the point where you mentioned about the rapid diagnosis is the most crucial part as well, because unless we don't know what we are treating, it's very difficult to get the patient out of the, I think, the critical situation as well. So I think we are all looking forward to that rapid diagnosis portion where, new technologies and everything comes into play.
I didn't go into too much of the rapid diagnosis because, it is very difficult to assess what facilities are available for different people who are there. But we are innovating, we are coming up with newer technologies, and I'm sure according to the availability, according to the cost and everything, soon things will be much more available to the common patient.
Yes, definitely. We are looking forward to that. I'm just two quick questions before we wind up the session. So as you mentioned, ma'am, that we actually have to try to avoid unnecessary testing as well. So as you mentioned about the urine culture, same applies for C. difficile as well, I think, because as you mentioned in the slide, unless it's liquid stools, I mean, I don't think that we have to send routinely for C. diff. So one issue what we face is that, I mean, just from my personal experience. So so we are dealing with transplant patients basically, and what happens is that post-transplant, the patients are exposed to a lot of antibiotics. So different varieties, maybe a lot of antifungals, antibiotics, and even reserve antibiotics are used. So what happens is that patient does end up having loose stools or some kind of GI distress. So what we feel is that once a patient start developing loose stool, we feel that, okay, what if it is a C. diff? Because the patient is immunocompromised and the patient is on immunosuppressant. So we just straight away send C. diff for the C. diff culture. So just your opinion on this, whether it's mandatory to just routinely send a C. diff, or should we wait and assess for any particular symptom? So what is your opinion on that, ma'am?
The CDC and the WHO, they have very strict guidelines when it comes to C. difficile testing, because C. difficile is rapidly transmitting bacteria, and it turns into bacterial spores, which are very difficult to get rid of. So transmission can happen and other patients can get affected. So the guideline is that if a patient is having certain factors, like at least 3 loose motions within 24 hours, and the patient is not on any laxative, the patient has the risk factors like age, prolonged hospitalization, multiple hospitalization, use of multiple antibiotics, maybe a chance for transplant patients, maybe there's a chance of graft rejection. All these criteria, there are risk factors of the patient, and this is the clinical symptom, then only we send for a C. difficile testing. And when the reports also come, it has to be taken with a pinch of salt, in the sense that The ideal is you test for GDH and toxin A, toxin B. And if only GDF is positive and toxin A, toxin B are negative, that patient is not having C. difficile. So this communication between the lab and the clinician is very crucial, and also with the clinical pharmacy, because treating for C. difficile, they usually give vancomycin, which is again a very strong drug. And so obviously, before jumping into conclusions and starting on some antibiotic therapy, there has to be a very good discussion between the lab, between the primary physician or the ID physician suspecting that it could be C. difficile, and the clinical pharmacist, that whether it is right to start certain antibiotics to treat C. difficile. And of course, the infection control team should also be if everything comes to a positive and okay, this is a case of C. difficile, the infection control team needs to be communicated that this patient needs to be isolated. You need to use soap and water for hand washing. You need to do the cleaning with hypochlorite. If the patient is getting discharged, you need to do a fogging with either UVC or with hydrogen peroxide. This working together for a C. difficile patient, suspected, diagnosed, or not branding that as C. difficile is very important.
Thank you so much, ma'am. And one more question. This is the last question. So you mentioned about the antibiogram as well, because that's very crucial part in selection of antibiotics. It varies from department to department as well. So is there any way, like as a clinical pharmacist or pharmacologist, how can we contribute in the preparation of antibiogram? So what's your comment?
Well, your contribution is the most important, Your contribution is very important, because if wherever you're working in the hospital, if you have an antibiogram, your contribution to the ID physician or to the primary treating physician regarding what antibiotic should be used empirically, looking into the antibiogram and giving a suggestion is very important, because antibiograms vary. They vary according to geographical location. They vary according to the hospital. It's a secondary care hospital, whether it's a tertiary care hospital, whether you have super specialties, whether you have a very high load of multi-drug resistance. So clinical pharmacist reading or pharmacologist reading the antibiogram and deciding along with the primary physician or the treating physician on regarding choice of empiric antibiotics is very important. Next comes the targeted antibiotics. That is when, like you have a culture report and then the clinician wants to start something on a hurry, but it's the pharmacist who looks into the patient background, the renal function, the liver function, the pattern of resistance present in that antibiogram, the geographical location, and suggesting the appropriate antibiotic, the dose duration. Everything is important, but definitely a clinical pharmacist has a huge role to play with the antibiogram.
Thank you so much, ma'am. I think those are like words of motivation for all the upcoming pharmacists out there. Because, yeah, right.
And so, I think the role of the pharmacist, the role of the microbiologist, it has, COVID has helped, definitely.
Yeah.
COVID has helped to, like if we were climbing one step at a time, it kind of pushed to climb 2-3 steps at a time. That is definitely there. But the role of the clinical pharmacist in antimicrobial stewardship and the role of the clinical microbiologist in proper diagnosis of infections and working together as a multidisciplinary team is very, very important. I mean, the faster the hospital administration recognizes this need, I think it's better for all of us to work together.
Yeah. Yes, that's so true. So thank you so much, ma'am, for those kind words. And thank you so much for the wonderful presentation. It was like well presented. You had covered all the basic concepts. And thank you so much for answering our questions as well. So I think I
Thanks,
won't take.
Sadia, for lending me her laptop,
Yeah, thanks to Sadia ma'am as well. So I won't take much of your time now. So I hope that we meet more for such great presentations, and we are looking forward to hearing a lot of other topics from you as well. So thank you, ma'am. Thank you once again.
Thank you so
So
much.
with that, we come
Thank
to the end of presentation. Thank
Yes,
you.
thank you. Thank you.